a mechanical ventilation conference, and welcome to the Intertube. I've been asked to talk about pediatric specific changes in mechanical ventilation, and sadly, there are not very many. But a lot of our data for pediatrics comes from adult data. We steal widely from work that you all do. So a lot of the disclosures I have is most of the things I do is off-label and investigation. These are the official objectives, so you can get CME credit. But really, all I want to talk about is the baby or child needs a ventilator. The baby or child happens to be on a ventilator. And oh my God, please get this baby child off the ventilator. And when I see a baby on a ventilator, I kind of look at whether the child has a normal lung, then I don't have to worry so much. Or if the child has an abnormal or diseased lung, then I need to kind of worry and think about all the different modes and pressure settings and such. Thankfully, pediatric patients don't get too sick, and thankfully, as a organism or species, our babies tend to be pretty resilient and heal very well, so we aren't extinct. When I do get sick with acute respiratory distress syndrome, it's relatively rare. The actual incidence of pediatric ALI and ERDS is low, 2 to 12 per 100,000 per year, as compared to adults where it's more like 3 times that, 3 to 306 per 100,000. It accounts for about 1 to 4%. For us, we see a lot more stuff that happens to kids, like falling, trauma, specialized surgeries that they need. And the mortality from pediatric ERDS isn't as high as adults, thankfully so. A lot of times it's secondary to other things like infection. We also use the Berlin criteria for grading ERDS, with higher scores being better and lower scores being sicker lungs. But let me bring up a case that I helped take care of and help frame the rest of this talk. Let's call this child J, who is in the care of a babysitter, and unfortunately the tub water was really, really hot. So when he stepped into it, his feet got burned. And it required a pretty severe burns to his whole feet up to his ankles. And he unfortunately developed compartment syndrome of his legs and required fasciotomy. This rapidly progressed to pulmonary edema, such that his x-ray like this. And it made me think like, well, this isn't normal lung, this is diseased lung. And oh my God, I'm gonna have to think about modes of ventilation. But first, let's try some non-invasive stuff. And for the most part, a lot of our patients now, as compared to even a decade ago, are used non-invasive strategies. And some of the things that have been helpful with non-invasive modes is the devices that we connect the ventilator to. So these are some series of non-descriptive, non-branded nose prongs that come in different sizes. And it brings up fancy law, Poisson's law. Didn't think you'd be doing math today, but I noticed other presentations had math, so I will happily show you more math. The developer for the nose prongs have this wonderful color-coded card where you can size up the nair size with the appropriate size of nasal prong. And let's just do some quick Poisson law math. So if we take resistance, which is the bottom part, it looks like a really complicated formula, but you don't need all the Greek letters. You can just take the numbers and pi, and then eventually come down with this white tube. The white prongs have 1/10 of the Greek numbers, and purple has 4.5 per thousand of the Greek numbers. And you can calculate an estimated amount of airflow that you can get through it. So since airflow is related to pressure against resistance, the white prongs get 10 pi flow. The purple prongs get 212 pi flow, which shows that the bigger the prong, the better the flow. And the reason this has helped us in our practice is that a lot of times when children are transported from another hospital to us, we just resize the prongs and their work of breathing is a lot less. And that just is the effort of reducing the resistance to gas. They're able to get better lung support, better oxygenation. I had to ask my colleague because I'm not a neonatologist. So I pulled up some papers and, hey, are we doing this in our NICU? They're doing NIPPV, which is a ventilator attached to nasal prongs, or nasal CPAP. There's all these trials and studies on nasal CPAP versus NIPPV. And the answer is yes. And they're like, well, what happened to intubating meconium kids? Oh, we still do that, but then we extubate them to nasal CPAP or NIPPV. Then we're all the intubated neonates. And then, oh, we don't have very many. Okay, how do you put in surfactant? They use an angio cap that's really long. And then they squirt it down there. And then they pull out the angio cap and then they put it on NIPPV. This blew my mind. My whole residency training was intubating kids. I remember going to 4 deliveries, intubating all 4, running back, delivering surfactant to all 4, and then putting them on ventilators, and then staying up most of the night, titrating ventilators and deciding what to do. But now it's a little different, which is probably better. So for us in the PICU, the advent of high-flow nasal cannula, kind of support this change in practice. The survival curve for from the New England Journal paper for high-flow nasal cannula is better than invasive ventilation and just giving regular oxygen, which kind of makes sense. Using a BiPAP machine over a large meta-analysis had favorable survival. Maybe these other strategies for using ventilators in a non-invasive form helps us to titrate to the level, and only the sickest patients need invasive ventilation. For you all who are not pediatric care providers, this next slide is probably the most important one of all this talk, and it's how to get the tube into the airway. And for me, the scariest part of getting the breathing tube in is I can't see this part of the airway, the glottis. So once you pass the airway through the vocal cords, it's not, yay, I'm successful. It's, did it go past the first tracheal ring, and will I have tracheal stenosis and horrible post-extubation stridor with my extubation attempt? So the airway for a pediatric patient is more funnel-shaped rather than narrow tube. And the cricoid ring is the first tracheal ring is a full ring that encircles the bottom of the funnel. Intubating a baby, these are slides. So I took slides from a variety of different resources. This is a slide set from the American Heart. I have some slides from the Society of Critical Care Medicine. I'd encourage you to take some of those classes and learn about different ways to support pediatric and neonatal patients. For the American Heart, they recommend these types of interventions with the intubation process for babies. There's more math. So if you wanted to size a airway for a baby, we take the age in years, we divide that by 4, and we add 4 to it. The sad part is some residents, they take months, so the months of the patient, and they come up with this huge number, and then the size of the airway doesn't match. So the easiest way for me, as a rule of thumb, to size the airways, look at the child's pinky, and then kind of get a gauge or the diameter of the pinky. It gives me a rough clue as to what the airway looks like. And I just pull that size tube, pick a half size smaller and a half size bigger. And when I look at the airway, I can ask for which tube would be the most appropriate. We do use a lot more cuff tubes, and in anesthesia, the new cuff tubes have a silicone bubble that reduces the risk of tracheal injury and tracheal stenosis. This is a radiograph from the Society of Critical Care Medicine. Not sure who volunteered their child to take this picture. This is almost as bad a picture as if you x-rayed a pregnant lady. But the tube is down the esophagus, and the stomach is full of gas. And the airway is clearly demarcated, not where the tube is. So hopefully this child was doing okay, but usually you can figure out the child, you've intubated the esophagus before you take the x-ray. Which goes back to our topic of your child is sick and the child needs to be on invasive ventilator. Okay, well, now we're on a ventilator and my lungs are sick. How can we help them? Well, we need to either have a ventilation problem or oxygenation problem or a combination of both. Ventilation problems can, if we pick really bad settings, like really high pressures or improper settings, we can cause lung damage. The ARDSNet trial, you well know, we use lower tidal volumes with improved survival, which brings up this idea of if we keep the lungs open, there might be a safe pressure and a safe volume by which a safe window, we can provide adequate support to provide ventilation and oxygenation. Or math, we can deliver oxygen by FiO2 and correcting anemia and making sure the patient's saturations are adequate. We can the cardiopulmonary interaction by monitoring our pressures and making sure that we're not overdistending or understending our system. And we have several different modes. This is a non-branded picture of an unnamed ventilator with these particular modes in it. And for the residents, I usually ask them, well, what settings are you on? Because they always look at the monitoring section and not the actual pressure setting. So this ventilator happens to be in the little circles for an aprv SIMV. That's a brand name for volume control regulation. The rate of 35, volume of 40. We do a pediatric fundamentals critical care course at Kapilani. They took away these slide sets, but I thought it was helpful as a way for us to pick initial settings, especially for babies. So these are some recommended initial settings for children less than 5 kilos. And likewise, they also have some recommended settings for patients greater than 5 kilos. But in reality, this essence is you need to pick a respiratory rate that matches with the age of your patient and match the I time to that as well, so that you don't have auto traffic. The different modes were talked extensively about in the last talk. I have high hopes for you all as people because you're not machines and our patients are people. So we have to deal with the parents and they have lots of questions for you. So I don't think a computer will be adequate to explain all of that to them. Let's go back to our case. So Jay is doing not so good. He weighs 13 kilos. Just first started on high flow at 20 liters per minute. Tubed in with a little bigger tube because his airway is a little bigger. So instead of a 4.0 cuff, we're using 4.5 cuff. So what ventilator settings do we do? Based on our fundamental critical care course, probably pick some SIMV mode, either pressure volume with the tidal volume that is sort of lowish and particular I time related to their age and respiratory rate, again, related to their age. So we did this, and his lungs did not get better. Well, maybe we need to start thinking of other ways of ventilating them. So looking at the adult data and all our adult colleagues, well, they like aprv, so let's try that. So aprv is a acute pressure release ventilation. Use a high CPAP to increase the mean airway pressure, and then you release it every so often to get ventilation done. When I looked at these pictures, the pressure settings seem very low, and some of the advantages to aprv is that you can have maybe a little less sedation. Maybe with the recruitment, you have a little less lung damage. But yeah, on the example graph, the pressures that they chose were below CPAP at 20. Like, Jay is way above that already. I don't think this is going to work. Um, for the patients that I have used aprv on, it's usually patients that needed a little more pressure, but had a lot of secretions, and we couldn't put them on oscillator for pulmonary secretion. So we have used this successfully for patients, but not when they're on very high settings. And currently at high pressure settings, they still do need quite a bit of sedation. There have been work on looking at pediatrics and APRP, but the data is limited and the number of patients enrolled are small. By far, our largest group that uses the machine is a high frequency oscillator. And there's different settings that you can pick. Residents are allowed to touch this. You can adjust the delta P. You can change the frequency. But essentially, high frequency is the area under the curve, regulates their ventilation. The displacement helps with getting more ventilation. And you can control the mean airway pressure a lot more accurately. There was these two large trials that looked at the oscillator use in adults, and it had poor outcomes with no difference between conventional arm and the oscillator arm, and worse outcomes with the oscillator. But we ignored that, and we put Jay on the oscillator. And he had foamy, bloody secretion. He ended up on a Hertz of 4, amplitude of 60, mean airway pressure at 35, with 100% oxygen. Terrible, but his oxygenation was pretty terrible. And you could argue that we could do recruitment maneuvers. Some of us do higher mean airway pressure to recruit lungs, then back off as the sat state. Brings up more things to talk about. We can monitor our children on the ventilator, using invasive means. And for babies in particular, if we're doing tons of blood gases, we can create anemia that needs transfusion after 3 to 4 days. So we try to lean more towards non-invasive means of monitoring their adequate levels of ventilation besides blood gases. So we use end-tidals, transcutaneous carbon dioxide monitors, and near-infrared spectroscopy or NIRS monitors. We could prone Jay, so we could put him on his stomach and do mismatch. I looked at flipping children, adults. The idea is that we're opening up dependent areas of lung. And the survival curve had better survival with the prone group compared with the supine group. To try maybe nitric oxide. In some institutions, it's harder to get. For us at Pediatrics, it's a little easier since the neonates benefit from nitric oxide. There isn't a lot of data on its survival, but it does help oxygenation. So the mechanism for the damage to the lung or the injury might regulate whether you choose or not to choose to use nitric oxide. Neonates, there's a lot of data that surfactant washout happens, and maybe giving surfactant for pediatric ERDS might be a benefit. There's a list of studies. The hard part about surfactant is it's soap. So you have to give quite a lot of it, and it kind of goes wherever it wants to. We can't aerosolize it, otherwise it turns into a foamy mass. And then if you give it in combination with other things, is it really helping or not? So that's been some of the difficulty of giving pediatric patients surfactant. For us, steroids have been a key factor. Maybe the instigation of the ARDS was related to bad asthma or bad bronchiolitis, and using small doses of steroids has been helpful. So the Maduri trial looking at ARDS, we've latched on to that, using sort of asthma dosing steroids with the taper. They had this nice survival curve of patients that did receive steroids compared to. We tried all this with Jay, and we tried the oscillator, tried proning. I think we even tried nitric, and he's still pretty sick. Maybe we just need to give up on keeping his lungs open. And his lungs turn into no lungs, there's not much left. And for us at Pilani, we actually do have ECMO program. And the hope is that with artificial lung support, that we can let the lungs do whatever it wants to do, even with no tidal volume, the closed lung, and let it heal, go through the process of inflammation, and essentially buy J time, become better on his own. ECMO itself is not riskless, so there's probably a sweet spot for ECMO. I always kind of refer back to this study from 1996, where they looked at different groupings of patients in selection for ECMO by risk mortality. So for the patients that were going to die, they're already going to die, no matter what you did to them. And the patients that were going to live, they're always going to live, no matter what you did to them. But in between, there's a group of patients that benefit from just being on the ventilator and not on ECMO. And there's a small subset of patients that if you put them on ECMO, their risk of death goes markedly down. And we saw that with ARDS. In ARDS post-surgery, post-trauma, the outcomes from large registry trials, about 70%. That's pretty good. Not as good as meconium aspiration, which is above 90%, but patients that are in ARDS that have really, really sick lungs that haven't gone into multi-organ system failure, maybe if we use the artificial lung machine and we rest their lungs completely, we can change their outcome and outcome overall. With the H1 outbreak, H1N1 flu outbreak, we were hit pretty hard at that time. Put out this great, New Zealand put out this great survival from JAMA paper, which invoked the Caesar trial by Giles Peake, led to Alan Combs put out the Eulolia trial, which also supports the use of extracorporeal support with versus conventional care. For us, locally, we use a oxygenation index, more math. It's a combination of the mean airway pressure with how much FiO2 the patient's receiving and what your blood gas shows. So if you're on higher mean airway pressure, you're a little sicker. If you're higher FiO2, you're a little sicker. If your PO2 is higher, that means you probably are extracting oxygen. We'd consider you and do an ECMO consult if your OI is more than 20, and we probably would put you on if it's more than 40. For adults, we started an adult program with a pretty good survival at Straub, and they had a wonderful outcome of somewhere in the 80% range for, especially with ARDS, so just lung injury. This was during the coronavirus period. I put the number of days on mechanical ventilation at 7. We like to know about these patients early. So if we can make a change before permanent lung damage happens, perhaps the overall outcome. It doesn't have to be 7 days. There are other patient reports that put patients on 14 to 21 days. I think with changes in technology, the extracorporeal life support devices can support patients that are sicker or different conditions such as malignancy or cancer. And we wouldn't put patients on that are already moribund or already with bleeding problems. Those patients probably do not benefit from being on. There is a current trial looking at heparin-free ECMO that I'm excited the results for. I'm waiting for that. Heparin-free or anticoagulant-free ECMO might be revolutionary for the care of these really sick people. So Jay ended up sedated, paralyzed, needed vasopressors. Even though we were on a high frequency, developed some renal insufficiency. His X-ray got worse. We cannulated him. This is not VV cannulation. We ended up VA cannulating him through the neck. And immediately post cannulation, his stats and ventilation, we rested him, but it was all controlled by the ECMO machine. After 5 days of ECMO, his lungs started to clear up, and we were able to get him decannulated, I think, towards the end of the week. Over the next couple weeks, he was able to get extubated and start rehab care. He came back to visit us. This is my colleague, Dr. Harrington, and our previous ECMO coordinator, analytical comments with him. We have a number of wonderful patient survivors that have come back to visit us and done very well and successfully. Well, with that, I guess before closing, probably should talk about how to get pediatric patients off of ventilators. So when they're on ventilators, we have to give them tons of drugs. Otherwise, they like to pull out their tubes. So after a few days of morphine, you build up tolerance. Versed, after midazolam, after, again, a few days, you build up tolerance. You can track withdrawal symptoms through withdrawal scoring tools. Irritable, you can vomit. Some strategies for weaning is if you pay attention to the drugs you're on, maybe we can use less drug overall by asking each day, can we cut back on one? Change the treatment regimen. Having a person in charge of the weaning plan, whether it's a pharmacist or the intensivist. Using alternative dosing for certain drugs, taking more Precedex or adding ketamine, helpful. Fortunately, there's no single predictive factor that tells us that a pediatric patient would successfully extubate. Even a spontaneous breathing trial can't predict. And I think it's related to the way that pediatric airway is shaped. So most of the extubation failure happens to be after you tube and then develop post-extubation. So this goes back to that original, that first, that is most important for the whole talk. If you can't get the tube past vocal cords, but you still have to worry about the tube beyond the vocal cords because down the line, you have to get rid of that tube. And that first tracheal ring can come back and burn you. There's a lot of swelling and edema. We do have a checklist of items that help us at Kipilani figure out if the child is ready for extubation. And if they pass all those items, we sort of tee them up to get the tube out. We have their little flow chart. And been working pretty well as a quality improvement. I have a list of references. And if you need help with transport, feel free to call us. I checked these numbers because I was told the 800 number doesn't get used too often. But both phone numbers are helpful for getting a pediatric transport team ready and sent off to your neighbor island community. And if you have any questions, feel free to email me. Thank you for your time. Question in the back. So there's two strategies. Right now we do a resting ventilator strategy, which is 10, 10, 10. It's 10, rate of 10, delta of 10, keep it 10. But it doesn't have to be that. For our cardiac patients that are in ECMO, we just choose regular ventilator settings because their lungs aren't sick, it's their heart. And there's a group that's been extubating patients. So if they have an airway problem and they're on ECMO for their airway, we've extubated 2 babies on ECMO. They eat on ECMO, and it's pretty surreal. But yeah, it's an area of investigation, and I think there's no one right answer. It's very patient. you so much. Please enjoy the rest of the conference.